Today is my final lecture this semester. Today we'll talk again about the disorders of thyroid. Previous lecture we discussed hyperthyroidism or pyrotoxicosis, and today we'll talk about hyper or low function of thyroid glands. Low function of thyroid glands. So, hyperthyroidism. I told you already. Да, Сергей, слушаю. Алло, слушаю. Так, я готов. So, hypothyroidism, low function of thyroid gland. First of all, about etiology. What may cause hypothyroidism? Iodine deficiency remains the most common cause of hypothyroidism worldwide. In areas of iodine sufficiency, autoimmune disease like Hashimoto's thyroiditis and iatrogenic causes like treatment of hypothyroidism are most common. Again, low amount of iodine in products. No iodine, no thyroid hormones. As a result, we have hypothyroidism. Hashimoto thyroiditis. This is autoimmune disease which causes damage of thyroid gland, inflammation and death of thyroid thyrocytes which produce thyroid hormones, and the result – пауза. Да, Сергей, слушаю? Да. Еще раз 5 секунд, продолжаю. And finally, iatrogenic causes. I told already, then when we treat hyperthyroidism or pyrotoxicosis, we can remove some part of thyroid gland or use remedies which block production of thyroid hormones. And as a result, we may expect sometimes to find patients in hyperthyroidism, so low production of thyroid hormones. Again, this is most common causes of hyperthyroidism. And you may see, for example, it may be primary causes like congenital. You know that all newborns checked for thyroid hormones because sometimes we have agenesis, so no thyroid gland. As a result, we need substitutional therapy from the first day of patient life. It may be defects of hormone synthesis, for example, iodine deficiency. It may be autoimmune disorders, again, Hashimoto's thyroiditis. It may be post-surgery, post-irradiation damage of thyroid gland. It may be tumors. Yeah? And rarely, you know that production of thyroid hormones controlled by pituitary, by TSH production. And in case of hypopituitarism, low production of TSH also may expect low production of thyroid hormones. So, underactivity of thyroid is usually primary, so due to damage of thyroid gland from disease of the thyroid, but may be secondary to hypothalamic pituitary disease, reduced TSH drive. It's one of the most common endocrine conditions, for example, with the UK prevalence of 1.4% in women and less than 0.1% in men. You see, this is usually disease of women, women disease. Causes of primary hypothyroidism. Atrophic autoimmune hypothyroidism. This is the most common cause of hypothyroidism and is associated with anti-thyroid autoantibodies leading to lymphoid infiltration of the gland and eventual atrophy and fibrosis. It's 6 times more common in females and the incidence increases with age. The condition is associated with other autoimmune diseases such as pernicious anemia, vitiligo, and other endocrine deficiencies. So this is typical autoimmune disease. Remember, when we talk about Graves' disease, this is also autoimmune disease, but specific with thyroid stimulating autoantibodies, which stimulate production of thyroid gland. Hashimoto disease, this is typical autoimmune disease when autoantibodies kill cells. In our case, cells which produce thyroid hormones, thyrocytes. Result, low production of thyroid hormones. So, if we talk about signs and symptoms of hypothyroidism, you know, if you know hyperthyroidism or thyrotoxicosis, it's very easy for you to answer such question because everything is absolutely opposite to thyrotoxicosis. Now let's first just name these problems. Symptoms: tiredness, weakness. That tiredness, weakness. Actually, thyroid hormones give energy. No thyroid hormones, no energy. And of course, patient will experience tiredness and weakness, no strength to do something. Dry skin, again, low energy, low reparation processes, and the result, dry skin. Feeling cold, feeling cold. The patient with thyrotoxicosis all the time feeling hot. Patients with hypothyroidism feeling cold. Hair loss, difficulty concentrating and poor memory. Our brain also needs energy. As a result, no energy, no normal functioning of our brain. Constipation. Remember, in thyrotoxicosis, diarrhea, in hypothyroidism, constipation. Weight gain with poor appetite. Again, opposite. In thyrotoxicosis, we have loss of weight with normal appetite. Here we have weight gain with poor appetite. Dyspnea sometimes, dyspnea. Hoarse voice, especially seen in women. Menorrhagia, so later oligomenorrhea or amenorrhea. Paresthesias, this is specific sensations in hands and legs. Impaired hearing. What we can find on actually examination of patients. Again, dry, coarse skin, cool peripheral extremities. Again, remember, thyrotoxicosis, skin warm and moist. In case of hypothyroidism, skin dry and cool. Puffy face, hands and feet. This is myxedema. This is specific edema which happened in hypothyroidism due to accumulation of glucosaminoglican. This is specific molecules, complexes of proteins and glucose, which deposited on the skin, and these molecules, they can trap water. As a result, we have very hard, specific edema. We can see this as puffy face, hands, and feet. Diffuse alopecia, loss of hairs. Bradycardia, remember, thyrotoxicosis, tachycardia, in actually hypothyroidism, bradycardia. Peripheral edema, we discussed already. No, delayed tendon reflex relaxation. So, you know, neurologists, sometimes they check reflex, yeah? And actually in hypothyroidism, everything becomes actually prolonged, I may say. The reflex relaxation delayed, everything delayed. No, carpal tunnel syndrome, pain in hands, serous cavity fusions. So specific fluid accumulated in serous cavities, especially typical for hypothyroidism in actually pericardium. And that's why presence of fluid in pericardium, one of signs you need to check hypothyroidism if you find presence of fluid in pericardium. So, clinical manifestation of hypothyroidism. Onset is usually insidious. You know, this is not acute disease which happened acutely. This is insidious disease because if it's actually Hashimoto disease, this disease lasts for many years, slowly killing thyrocytes. As a result, again, onset usually insidious. And patient may become aware of symptoms only when hypothyroidism is restored. Meaning what? That again, this is a patient, no elder patient. Yeah? And when an elder patient feels himself weak, tired, I don't know what he believes. No, I'm too old, that's why I'm so weak. Yeah? And patients understand that something was wrong only when we treat him and when his condition becomes hypothyroidic. So when his level of thyroid hormones becomes normal. Patients with Hashimoto thyroiditis may present because of goiter rather than symptoms of hypothyroidism. And goiter may be not large, but is usually irregular and firm in consistency. Again, in Hashimoto disease, sometimes we have enlargement of thyroid glands and patients search for medical care because of presence of goiter. The skin is dry and decreased sweating, thinning of epidermis and hyperkeratosis. You know, actually, some skin look like as, you know, old, rough, dry. One of signs, this is hyperkeratosis on elbows. Да? We talk about syndrome of dirty elbows. Dirty elbows. It looks like as some dirty stuff on elbows. Да? Really, this is hyperkeratosis. So presence of actually presence of dead skin cells. Да? That's why I remember sign of dirty elbows. Increased dermal glucosaminoglican content traps water, giving rise to skin thickening without pitting, myxedema. So we use term myxedema, telling about edema happened in hypothyroidism. Remember cardiology. In cardiology also we may find patients with edema, but patients suffer from so-called pitting edema. When you press for example, patient's leg, you remove your finger and you can find pits, the excavations. That's why we talk about pitting edema. In myxedema, in hyperthyroidism, water trapped by glucosaminoglican, this is hard edema, and that's why if you press, nothing happens. No pitting edema, I may say. Typical features include puffy face with edematous eyelids and non-pitting vertebral edema. This is paler, often with yellow tinge due to keratin accumulation. Again, face is very specific. Remember again, pyrotoxicosis. Face with big eyes, very emotional. In hypothyroidism, vice versa. Face like a mask, no emotions, like a mask. Face edematous. Eyes look like a small, in pyrotoxicosis, big eyes. In hypothyroidism, small eyes, but you can understand that eyes can't enlarge in size or shrink somehow. Eyes look like smaller because of edema. And that's why eyes look like it's placed somewhere deep in the face. Nail growth is retarded and hair is dry, brittle, difficult to manage, and falls out easily. In addition to diffuse alopecia, there is thinning of outer third of the eyebrows. Again, we don't know why exactly, but patient lose his eyebrows, especially internal, actually 1/3 of eyebrows, 1/3 of eyebrows. This is also specific for hypothyroidism. Okay, for example, this is typical face of patient with hypothyroidism. What we can see? Edema, around eyes, and the result, eyes look like a small, eyes. And eyebrows, you see 1/3 of eyebrows lost, loss of 1/3 of eyebrows. Puffy eyes, thickened, pale skin, sometimes with yellow cast, Now again, another view. On one hand, typical view of old man, but actually what you can see again, loss of eyebrows, you see, thinning of lateral eyebrows, here is present, outer absent. Puffiness of the face, puffiness of eyelids, edema of eyelids, increased number of skin creases, the increased number of skin creases. But patient may say, again, I'm all this, why I have all this stuff. Dull, expressionless, beadless faces. Again, what actually I told you, that expressionless, there are no emotions, face like a mask. And patients with hypothyroidism, even told specifically, he talk with you slowly, he needs to understand what you ask him. That again, opposite to stereotoxicosis, when patient is very fast, do everything fast, reply, talkative. Hypothyroidism, absolutely opposite. That slowly, actually thinking, slowly answering patient, Everything do very slow. Now, other common features include constipation, weight gain despite a poor appetite. Constipation again, without thyroid hormones, everything become work slower, including intestine. As a result, patient experience constipation. Weight gain, usually modest and due to mainly to fluid retention in myxedematous tissues. Again, it's not accumulation of fat. This is accumulation of fluid. In myxedematous tissues. Libido is decreased in both sexes, and maybe oligomenorrhea or amenorrhea, no menses in long-standing disease. No, menorrhagia is also common. Fertility is reduced, and the incidence of miscarriage increased. Actually, all gynecologists know, if women experience problems with fertility, first check thyroid hormones, because it may be even subclinical hypothyroidism, and no signs at all, and only one sign, only one presentation. This is low fertility. Prolactin levels often modestly increased and may contribute to alteration in libido, fertility, as well as causing galactorrhea. Why prolactin? Because again, it's produced by pituitary. And in case of actually low production of thyroid hormones by peripheral organ like thyroid, pituitary try to increase production of TSH, and together with TSH, other hormones also may be produced as a result, causing such effect. Myocardial contractility and pulse rate reduced. Again, one of the most common clinical signs, this is bradycardia. But not only number of contractions decreased, but actually force of contraction also decreased. This leads to reduced stroke volume and bradycardia. Increased peripheral resistance may be accompanied by hypertension, particularly diastolic. Blood flow is diverted from the skin, producing cool extremities. The main problem of patients with hypothyroidism, this is not because they become slow. Hypothyroidism may kill, and mostly due to development of severe heart failure. Pericardial effusion occurs in up to 30% of patients. I told you about collection of fluid in pericardium. No, rarely compromise cardiac function. Usually this is finding. You do ultrasound examination of the patient and find some fluid in pericardium, the hydropericardium so-called. In this case, check hormones, thyroid hormones. One of possible causes, this is low production of thyroid hormones. Fluid may also accumulate in other serous cavities, and in the middle ear, giving rise to conductive deafness. Again, patient may experience, sometimes patients go to ENT specialists because of impaired hearing, for example, Also, I told you, sometimes they go to ENT specialists because women, they find that their voice changed and voice becomes hoarse. Women start talking like men. What's happened? You know, these glucosaminoglycans, I told you, may accumulate not only on the skin, but they may accumulate in other actually mucosal tissues, and for example, they may accumulate in vocal cords. If glucosaminoglycans accumulate in vocal cords, they trap water, it causes what? Vocal cords becomes harder, becomes actually bigger, wider, and of course they can't vibrate with high frequency. They can vibrate with low frequency, as a result, voice becomes hoarse, like a man's hoarse, like a man's actually hoarse voice, because actually frequency of vibrations decrease due to edema of vocal cords, the edema of vocal cords. Memory and concentration are impaired. Memory and concentration are impaired. No and hoarse voice, occasionally clumsy speech of hypothyroidism due to fluid accumulation in vocal cords and tongue. Again, even tongue may become bigger due to accumulation of fluids in the tongue too. That's why even speech can be changed. So, investigations we should do or should be done to confirm hypothyroidism. Of course, the most sensitive, the serum TSH. TSH, thyroid stimulating hormone, is the investigation of choice. The mechanism is clear. I told you again about feedback mechanism, And if peripheral hormones T3, T4 decrease, pituitary try to stimulate actually thyroid, produce more hormones. Body needs more hormones, and that's why production of TSH increase many times. And actually, sometimes we see high levels of TSH even with still normal levels of T3, T4. That's why, again, TSH is the most sensitive test for hypothyroidism. Now, low total of free serum T4 levels confirms that hypothyroid state and is necessary, as if there is hypothalamic and pituitary disease, TSH may be low and normal. Again, sometimes to differentiate primary and secondary hypothyroidism, we need to check also peripheral hormones, T3, T4. And what we'll find, if it's primary hypothyroidism, T3, T4 low, TSH high. If it's secondary hypothyroidism, all hormones, TSH low and T3, T4 low. But usually, secondary hypothyroidism never becomes very severe, because even without stimulation, thyroid can produce sufficient amount of thyroid hormones. We find hypothyroidism, but not very severe, because again, thyroid normal and can produce hormones even without stimulation by TSH. Again, using this table, you can see what happens in different actually problems with thyroid gland. For example, primary hypothyroidism, thyrotoxicosis. What happened? Of course, TSH decreased, suppressed due to feedback mechanism. Total T4, free T4, T3, all increased. Primary hypothyroidism, so low production of thyroid hormones. Vice versa, TSH increased, and all hormones T4 low. Sometimes it may be even normal, low normal, because again, pituitary try to stimulate, and again, I told you TSH, this is the most sensitive test for detecting of hypothyroidism. In case of TSH deficiency, pituitary problem, what we'll find? No, TSH may be subnormal, decreased, and T4, T3 may be low or low normal. Again, I told you that it never becomes extremely severe. What to do with patients with hypothyroidism? How to treat? Actually, now it's not a problem at all. We have hormones in tablets. We have thyroxine. Thyroxine, very cheap and very effective remedy. Thyroxine, this is T4 in tablets. You know that thyroid hormones, very simple hormones. They can't be digested in our intestine. And that's why we can use this as a tablet. For example, insulin we need to use as injections because insulin protein, and we can't give tablets of insulin, it will be digested. Thyroxine, very simple. Patient take 1 or 2 tablets, no amount he needs to substitute his production of thyroid hormones, and patient recover completely. It's like a miracle. You start giving tablets and you see that in 1 to 3 weeks, patient changed completely. His face changed, his behavior changed, the patient recovered. And no, of course, substitutional therapy should be given all his life. No, what's the problem to take 1 or 2 pills per day? It's not a problem at all. That's why it's so important to detect hypothyroidism on early stage and prescribe proper treatment. Prescribe proper treatment. If you do this, again, we can recover our patients completely. Recover our patients completely. You know, we have a lot of disorders we can do nothing. We have a lot of disorders we can try to treat, but patient never will recover completely. But in case of hypothyroidism, in many cases, we even know that patient will suffer from hypothyroidism. For example, we detect that patient suffer from thyroid cancer. What we should do? Remove thyroid gland completely. No choice. And what to do then? Just give tablets of substitutional therapy, and patient will live all his life without thyroid gland and without problems because he has good substitutional therapy. How to check? Is it sufficient therapy or not? Just check periodically TSH. If we give sufficient amount of thyroid hormones, TSH will be normal. Very simple control. TSH is the most sensitive test, not only for detecting of hypothyroidism, but also to control our treatments. Control our treatments. Okay, that's all about hypothyroidism. That's all about hypothyroidism. Okay, it was final lecture in this semester. See you next semester. We continue our lectures. You know that you'll have propedeutics in spring semester, and you will have some exam. You will have some exam in propedeutics. So good luck in your session, in your exams, and actually try to have some fun during winter vacations. Bye.